Hello, my name is Michelle Morand. I am a precision cancer medicine patient educator and advocate. I've been working for the last 14 years with an expert team leading the charge to bring leading edge diagnostics and treatments to patients on the front lines right now, get their doctors on board with prescriptions, and get people as well as possible as soon as possible. What you're about to see is a video about tumor DNA liquid biopsies. These are either diagnostic or monitoring tests using blood. We're going to tell you all about them, how they help you, why they're going to benefit you, and how you can make sure that you're using a really good quality liquid biopsy test and not wasting your time or financial resources. Hit the subscribe button. Make sure that you are staying up to date with the most current videos that we post. And don't forget to subscribe for our free online education program. You get lots of resources for free, lots of information about precision cancer medicine diagnostics and treatments, and you can join us weekly for a live Q&A and get all of your questions answered. Hello, my name is Michelle Morand, and I'm a precision cancer medicine educator and advocate, and I'm here with Alexander Rolland, the cancer guy, expert researcher in precision cancer medicine, the latest science of cancer care. Today, Alex wanted to share some information with you about something we get asked about a lot through our YouTube and Facebook and all of these things, is should I have tissue testing for my cancer treatment options, or should I have liquid biopsy? What is the difference even? So Alex has put together a presentation for us to talk about tumor DNA sequencing, both tissue and liquid, when you'd use one or the other and why.
Yes, this is a very big question. A lot of people ask this, and there's a multitude of different things going on here because there's so many different types of liquid biopsies. We've now got liquid biopsies that look at methylation of DNA and all kinds of different things. And, then there's the new signature test and so on. And so I think it's really important that people understand the differences of what these tests are and how they can be used most effectively. Because a lot of people just end up ordering these tests and not knowing how they can be applied or used and ordering the wrong tests.
Yeah, it's one of those things where a little knowledge can be a dangerous thing. You've heard of tumor DNA sequencing, or you've heard of liquid biopsies, and you Google and you think, oh, this one's approved, that must be a good one, but it's not going to help you necessarily.
Yes. Well, unfortunately, a little knowledge is kind of something that everyone suffers from in cancer right now because there's just so much data out there and there's so much to know. So I would say that I'm one of these people that suffers from a little knowledge. However, I might have a little more knowledge than the average person.
Maybe. Hence, we make these videos. When people ask us a question frequently, we know, okay, this is a pretty common issue that people are really struggling with. So tell us all about it, Alex.
Well, the big thing is most people want DNA testing these days. They want tumor DNA analysis and they get it. And that's because they understand that most of the targeted therapies and most of the drugs that they're going to be taking, knowing your unique genetic and molecular makeup of your tumor is essential in determining which drugs are going to work for you and which drugs are not going to work for you. Very, very important because you don't want to be spending time on a drug that doesn't work. So we discussed the differences of that in a previous video that should be up pretty quickly on tumor DNA sequencing.
Yeah, I'll make sure that gets linked into the description of this one for anyone watching at home. That's about tumor DNA sequencing, solid tissue testing, how to tell what's a good test and when you need that.
Yeah. So, if you're going to go through the expense of spending money on tumor DNA sequencing, it's really important you do the right test. And that kind of spills over into the type of tissue you're testing. And so, as most of you know, there are liquid biopsies now that you could do tumor DNA testing. And yes, blood is considered a tissue. Because that's another big question. They're both tissue testing. So traditional tumor DNA sequencing, obviously used to determine targeted therapies for each patient. And so the new forms are called liquid biopsies, but that's a general term that's used for anything from blood or urine or spinal fluid. So liquid biopsies in general, we're going to be talking about are blood-based liquid biopsies. They're similar to tumor tissue-based sequencing, but they use the tumor DNA from the blood. And yes, tumors do release their DNA into the blood in a variety of ways. And that's important too, because we're going to talk about that. A lot of people either they've used up their biopsy sample, or they just can't get a biopsy because the tumor is in a place that's hard to reach. And also other people who've had tumor DNA sequencing maybe 10 years ago, and the disease has recurred, and they want to know if there's new, mutations. Everyone, needs to know how to use these tests. So we're going to discuss that moving forward. So some of the benefits of tumor DNA liquid biopsies is that they are a good way to detect new and emerging mutations. A classic example is when women are on estrogen positive treatments, or when they have estrogen positive breast cancer and they're on treatment for that, they can often depend what we call an emerging mutation. The emerging mutation typically occurs in what we call the estrogen receptor gene, or ESR1 gene. And these mutations can prevent the standard anti-estrogen therapy from working. The good thing is there's a bunch of brand new FDA-approved estrogen receptor degraders called SERDs, and they are quite effective with certain mutations. So detecting emerging mutations is a very important thing, because it tells us what new targets your cancer is using and what new drivers are there that weren't there in the previous tissue. It also tells us how well your current treatment is working, and it helps identify new mutations that can change your treatment options to make your treatment more effective, like which driving mutations you have in this moment. Additionally, blood-based tumor DNA testing can tell you what all of the tumors in the body are doing at the same time in real time. So in other words, today, what's going on today? What is your driving mutation? A lot of people get a little confused on that. And I like to explain it that we have passenger mutations and driving mutations. And a passenger mutation can become a driver mutation at some point in your tumor treatment. And it's important to know what your driving mutations are today. And the perfect way to do that is with a tumor DNA-based liquid biopsy. And so blood-based DNA testing can provide you with current information and more comprehensive information for key elements of cancer, like what tumor or what mutations are driving your cancer right now. Additionally, we have patients, and we're seeing more and more, that have multiple drivers. And so we don't know which ones are actually driving their cancer right now today. And so the liquid biopsy provides us with a great tool to determine which driver is actually driving the bus today. So, advantages in general are that they're a great way to get further information and determine whether you're fit for hundreds of targeted therapies, immune therapies, antibody drug conjugates, and also a great option when tissue is not available. And obviously, knowing which mutations you have is very, very important.
Because without that information, as you probably know, all your doctor can provide you with any confidence is the standard of care, which usually involves some form of chemotherapy and maybe a targeted therapy, but there's a fair amount of guessing going on there. And exactly. At this time, you don't need to be guessing about what's driving the bus at any time, is what we're trying to tell you here. Yes, ideally, this is a big part of everybody's cancer treatment program. Ideally, would be the tissue testing as well as the blood-based testing, I would think.
Yes, exactly. Another important thing that liquid biopsies can do is they can tell you what your relative level of a driving mutation is. And so, in other words, you'll often see this if you get a liquid biopsy test. You'll see a bunch of different mutations, and you'll see the percentage next to it, and that gives you the relative percentage of that mutation within your tumor sample. And that's important information because it tells you, that's probably a driver. And also, it also tells you if you have a driver that occurs at a very low percentage, do you really want to be targeting it right now if it's only, present in a very small percentage of your tumor cells?
Yeah, and I think we talk about this in the next slide, actually, Alex, that what frequently happens is that medical oncologists who are really trying to do the best for their patients, and they're trying to apply tissue-based testing, and so they get a tissue-based test. It doesn't necessarily have this relative expression information, and they prescribe a targeted therapy for the mutation that was found for that particular patient. But unfortunately, it was only present in a small percentage, and the targeted therapy is not that effective. And the doctor doesn't necessarily understand why or what to do next, and just kind of that's where you might unfortunately hear the term you failed, failed on XYZ treatment. When in fact there would have been a therapy that could have been far more effective for you if we just understood this data. Which of those mutations that showed up in your DNA testing are the most prevalent? And the liquid biopsies really help to identify that.
Yeah, I think that's an excellent explanation, Michelle. Thank you. And by the way, I just want to mention, while I do set up the PowerPoints here, Michelle's the person who turns them into layman terms and helps explain them, because really us scientists, we can't explain anything properly.
Maybe.
So thank you, Michelle. I think that's a great clarity,
Yeah.
on
Well, I
this.
just try to think, okay, I don't understand this. What do I need to add? And there's a lot of back and forth here behind the scenes of me saying, what are you even saying here? What does that mean? And but I figure if I can wrap my head around it, then I can help you folks at home understand it better. And that's important, because this is all about you being able to action on this stuff successfully for yourself.
Yes, exactly. And so I think you've really outlined the whole point here, is why would you be on a treatment that doesn't target the vast majority of your cancer cells?
Yeah.
So knowing that percentage, that relative percentage, is really important.
Yeah.
However, there's a little more to it than that. And unfortunately, I see people, based on a lack of knowledge, and doctors specifically, making poor treatment choices, thinking they understood the test when they didn't. And so we're going to discuss that right now. So the disadvantages of liquid biopsies first, I'm going to cover those, is they're not able to look at entire genes in many cases. It's limited how much DNA you can actually get. But they're usually pretty good. They're usually able to get a substantial amount of the gene, but they can miss key mutations. They're not as good as tissue. They're also limited in the amount of genes that can be examined, although that is improving every year. I think some tests are looking at as many as 315 different genes, or at least they're important parts of those genes. Yeah. And so the important thing that I want to talk about is, while these tests can give you the relative percentage of a mutation compared to other mutations in the sample, that's not always an accurate way of determining what treatments are going to work for you and what treatments are not. And so we're going to talk about that. There are basically two types of liquid biopsies, and this is really, really important. And when we first started ordering liquid biopsies way back when they first came out, one of the things that I started complaining about to the liquid biopsy companies is they didn't put the percentage that the tumor, that the mutation was involved in. And so when I contacted the companies that were running these tests, they said, well, we can't really be positive that, because we have to amplify the DNA so much in order to be able to test it. So we'll get this tiny, minute amount of DNA from the blood, and then we have to amplify it, amplify it, and amplify it, and amplify it. And in that process, some data can be over-exaggerated or lost. So we put we don't like to give the relative percentages, but we're willing to do that with a claim that it's not to be used for diagnostic purposes. And so you'll see that in all of your tumor DNA liquid biopsies, is this little clause saying that they give you the percentage, but it's not to be trusted. Okay, so they'll give it to you just because you're asking for it, but it's not to be trusted. And here's why, is because there's two types of tumor DNA liquid biopsies. There's discovery liquid biopsies, which is what we've been talking about. What mutations are present now upon diagnosis, what treatments do you need to target? And they usually cover many, many genes. And then there's also monitoring liquid biopsies. And these tell you, what the real percentage of that mutation is in your body. The problem is the discovery liquid biopsies, they look at many different mutations. The monitoring liquid biopsies can only look at one mutation at a time. Now that is changing. I mean, you can obviously do 2 or 3 different mutations at a time. But, for our liquid biopsy, we use 2 vials of blood just for one mutation. And so, we're trying to really determine what the real level of that mutation is, not just what the claimed level it is relative to the other mutations.
So if I can just pause here, just so the folks at home understand what Alex is saying so far. There's a time and a place for each of these.
Yes.
If you don't have a good biopsy sample, or you perhaps it's going to take too long for you to get one, or whatever it is, and you want to find out You want to help your doctor have more options for you than what they're offering. That's when a discovery liquid biopsy would be good. There are some very good ones out there that look at 300 or so mutations. That's the minimum you should be
Genes,
expecting, right?
genes,
Pardon me? Yes, genes.
300 or so genes.
Pardon me. There is a big difference as he keeps trying to drill into my head. I'll get it one day. Point is, discovery liquid biopsies have a place if we don't have tissue, or again, all those reasons I just mentioned, to help you get into a ballpark. Think of it as we've got this vast universe of possible things that could be happening with your cancer. The discovery liquid biopsies help to get that into a ballpark. The monitoring liquid biopsies help you hit the bullseye, because that tells you right away what percentage of that particular mutation that was found in my discovery liquid biopsy is actually in my body now. So you're going to say more about that, but that's kind of there's a time and a place for both of these. They work in tandem for your benefit.
Yeah. So the way you shouldn't really be doing treatment decisions on a diagnostics liquid biopsy without doing a monitoring liquid biopsy.
Yeah.
So what we do is we'll do the diagnostic liquid biopsy to determine, what mutations are there, and then we'll do the monitoring liquid biopsy to determine who the specific driver is at that particular time.
And then your treatment plan is based on that information. Oh, this one is here and 60% of your tumor cells are 80 or 90. That's definitely one we want to be targeting.
Yeah. So this slide just recapitulates what I was saying earlier. The discovery liquid biopsies look at many genes, and while they often do report the level of each specific mutation, that's not to be used as a guide because it's not accurate. And they say that in the report. This is due to the fact that they need to amplify the small amount of blood-based tumor DNA in order to run the test. So while the amount of the specific mutation is accurate compared to other mutations in the test, it's not accurate as to the level of that mutation in your body at that time. And that's the important take-home message, that last sentence.
Yeah, so think ballpark. This gets you in the ballpark of understanding.
Yes, exactly. So monitoring liquid biopsies, they look at a single mutation, and they can typically identify if the mutation is present at a very low, very small percentage. This makes them excellent for determining if your treatment is working very early on, because they can detect the presence of a mutation at a very, very low level in the blood. And they can help determine early recurrence, or to tell you if you're in remission. And so we use a specific type of tumor DNA monitoring liquid biopsy that we've developed. We spent many years developing it, and we've developed it with the help of other great pharma companies. We've really got it to the point where we believe it's one of the best and most accurate liquid biopsies out there right now for its purpose. So this is the Liquid Biopsy Labs tumor DNA monitoring liquid biopsy. And it's unique in the sense that it looks at tumor DNA from exosomes. So in short, exosomes are membrane-bound vesicles that tumors use to spread their DNA mutations, RNA, proteins, microRNA, other tumor-causing or oncogenic molecular identifiers. And they spread these around the body in order to metastasize, or create areas that are going to be beneficial for tumor cells to grow and metastasize. And interestingly enough, there's new data to show that they can also convert normal cells into tumor cells. It's kind of like a vampire. They bite you, and all of a sudden you become one of them. And so, we know that exosomes are how cells communicate with each other, but we didn't understand the important role they have in cancer. And so, we believe that exosomes are the future of cancer. They are going to be targeted. So pretty soon we're going to see drugs that just target exosomes and not the main tumor, and prevent the whole metastatic process from occurring. Importantly, tumor-based exosomes are only released by tumors when they are actively growing and metastasizing. And this is the take-home message here. So the altered and bad mutations that are helping that tumor grow and metastasize are packaged into exosomes, but they only can release them when they're growing, when it's a safe time for them. They're actively growing and metastasizing. And so often we'll see the level of the exosomes go down significantly when a person is on effective treatment. We just won't see their tumor-based exosomes there. We'll get, we'll look at a bunch of vials of blood and there'll be hardly anything there. And then in patients that are not responding or not on treatment, we'll see an incredibly high amount of tumor-based exosomes. But the important take-home message is that blood-based DNA testing, and we're talking about all types of liquid biopsies, suffer from the fact that tumor-based DNA can come from a variety of sources. So the tumor DNA in your blood, it could be from exosomes, which are part of that metastatic process. It could be from circulating tumor cells. And, as we know, 99% of circulating tumor cells cannot metastasize. It's only the stem cells that can actually metastasize. So a lot of these circulating tumor cells just kind of drift around in the blood for a while and then get killed by the immune system at some point in time. And it also can be from dead tumor cells that have released their DNA. So let's say you're on a chemotherapy drug, kills the tumor cells. These tumor cells, burst open and their DNA gets released into the blood. And so there's three different sources here of DNA in the blood, and they all mean something different. So if you're not using exosome-based liquid biopsies for monitoring purposes, then the results will often be misleading. And that's because the source of the DNA could be from circulating tumor cells, which are unlikely to metastasize. So that doesn't tell you whether your cancer is really, growing and spreading. It just tells you have circulating tumor cells in the blood. Also, if you have a dead tumor cell that's affected by treatment, then the number of that mutation is going to be high in your blood, but that doesn't tell us that you're not responding to treatment. And so that's like a false positive. So if you're getting DNA in the blood from tumor cells that have been affected by treatment and have just split open and released their DNA into the blood, then you're going to have a very high number on your liquid biopsy. And, the doctor's going to misinterpret that as you not responding to treatment, when the reality is it's just dead tumor cells that have been releasing their DNA into the blood. And then also you can have the exosomes that are actually a metastatic process. So dead tumor cells, are going to give you a false positive, and the exosomes are going to give you the real indication of whether your tumors are actively growing and metastasizing or not, because exosome release is based on a metastatic process. So key message for blood-based tumor DNA monitoring is only DNA from exosomes that tells us whether your tumors are active and metastasizing or not. The other sources of tumor DNA in the blood are very misleading. And so, we've spent a lot of time focusing on a protocol that only isolates tumor DNA from exosomes. And, we have it perfected now. We did a seminar on that, and we've been doing this for a long time. So, we've got tons of data, and it's well established now that, exosome-based liquid biopsies are the only type of liquid biopsy you should be doing for monitoring. So, yeah, exactly what does this mean? This means that if you have a high amount of tumor DNA identified in a discovery, a multi-gene test, a portion of that is coming from dead tumor cells. And this can result in false positives and assumptions that the treatment isn't working, when in fact it's working very well, because the DNA is from tumor cells that have been killed. Important point. And so if you're still a little confused, spend some time on this slide and really make sure you understand that. We've seen patients get removed from treatment. A classic example I'm going to get into is something that I feel is one of the biggest advantages of exosome liquid biopsies and monitoring liquid biopsies. And we're going to talk about that. But I just want to summarize here, is that the exosome liquid biopsy is specific to tumor cells that are actively metastasizing. It doesn't necessarily pick up new and emerging mutations because it's only looking at one mutation at a time. So it's not a good tool for discovery. It's only a good tool for monitoring. So one of those important situations is with immune therapy. But just a little summary on that. So our protocol is using it's what we call a digital PCR-based protocol. It's incredibly accurate. It can detect one piece of DNA in 20,000 pieces of normal DNA. Now, we like to go with 18,000 pieces of normal DNA. 20,000 pieces of DNA is the actual number on the chip of potential spaces that we can test for. most of the time we see it's more like 1 in 18,000. So just to be more accurate, you know, the test is designed to detect 20,000, but typically we like to say it's incredibly accurate, 99% accurate in 1 in 18,000 pieces of normal DNA. So as many people understand, there's a new type of therapy. Well, it's not new, it's been around for quite a while, actually. And we were one of the first in Canada to ever use it. It's PD-1 inhibitors or immune therapy, and they've been a game changer for cancer treatments. So what can happen in about 20 to 40% of patients on immune therapy is they experience something called pseudoprogression. And so the way immune therapies typically work is they trigger the T cells that are the ones that kill tumor cells. They call it CD4 tumor infiltrating lymphocytes, also known as TILs. And so these basically these immune therapies really increase the amount of TILs. And these TILs go inside of the tumor, they multiply within the tumor, or they expand the tumor, and they can make the tumor look a lot bigger on a scan. And so, you know, normally you'd think, okay, well, you know, my tumor, you know, I'm on immune therapy. My tumors have gotten bigger since I've been on immunotherapy, and my doctor's concerned that the immune therapy is not working. But he also doesn't know if it's pseudoprogression, so he wants to just wait it out and see. So, you know, you say, well, why not get a PET CT scan? Well, that doesn't work either for pseudoprogression because the immune cells and the tumor cells both really like the FDG sugar isotope that PET CT uses. And so you could have a dead tumor cell that's full of tumor infiltrating lymphocytes, but it's going to light up on a PET CT scan because those immune cells are drinking up all the PET fluid. You know, so they make it look bigger. So, you know, using a PET scan is not a way to determine whether you have pseudoprogression or not. And so, you know, this is one of the biggest problems we have seen with doctors is they can't tell whether you're getting pseudoprogression or not. And, you know, often they take patients off immune therapy because they think it's not working. Or they keep patients on immune therapy when it's not working.
Yeah.
And so we're going to talk about how monitoring liquid biopsies can tell the difference. The monitoring liquid biopsies, because they identify the metastatic process, if the immune therapy is not working, then those tumor cells are still going to be pumping out those exosomes. If the immune therapy is working and the TILs are inside of the cell and killing that cell from the inside out, that cell's not going to be able to release any more of its mutations via exosomes. It's not going to be releasing any exosomes. And so we've seen many cases where we've had patients where the doctors said, oh, I don't think the immune therapy is working. And we'll look at one of their key driving mutations and see that it's actually really low and tell them, hey, yeah, no, this is still working. Even though, you know, the tumors are bigger and they look hot on a PET CT. We've also seen cases where, you know, the patient feels really good and they're confident the immune therapy is working. And, you know, there is some pseudoprogression, but they're confident that the immune therapy is working. The doctor's not sure, so they just want to keep them on it. And we test them and we see that, you know, their driving mutation's gone up significantly. And so we know that that immune therapy is not working, and we have to let the doctors and the patients know there's no point staying on the immune therapy. You have a high level of this exosome-based mutation in your blood.
At that point, folks, it's not game over. At that point, it's time to go back to the well of either the tissue or blood-based discovery test, if you haven't had one already, or recently, and have a look at what are all the big possible factors in your cancer, and then essentially rinse and repeat the process. That is the nature of precision cancer medicine, really. I mean, sometimes what I see with Alex and his team is the nature of the molecular features of the patient's cancer are such that they are able to identify treatments that will knock it out of the park or give them that complete response. And other times it's okay, we found some treatments that are really going to give you a significant amount more time, but we're going to have to do like serial treatment. We do this to target these mutations, and then this to target this, and this to target this. And as this is happening, if you're monitoring with those blood-based tests, you know exactly when it's time to switch. You know when there's no more of this mutation, it's all been taken care of and it's time to switch. So the two in tandem, as I said, in a kind of a rinse and repeat fashion, really are the best way for cancer patients to make sure you're on the right treatment always, not just that you've started out on a good one, but that it's working as well as it should. You're not getting more of it than you need to, and that if there's anything else that's starting to come up now, you're appropriately targeting that.
Yeah. And so, we had a perfect example the other day. I had a patient with estrogen positive breast cancer. She had a PIK3CA activated mutation that was targetable with alpelisib. She had two HER2 mutations that were potentially targetable with a drug, a HER2 TKI. And then she also had what was it? It was a BRAF V600E mutation. And so she'd been experiencing progression while on treatment, and we wanted to know why. And so what we did was we tested her PIK3CA mutation, and it was 0, or below 1, so insignificant. So we knew that was not driving the cancer. And her doctor was willing to put her on alpelisib. So that was an important thing, because obviously alpelisib wouldn't have done much for her at that time in her treatment. And so then we tested her BRAF V600. That was also very low. So we were able to rule out those two treatments and say, don't bother with BRAF inhibitors and don't bother with PIK3CA inhibitors. We know now, simply by deduction, that it's actually these HER2 mutations that are driving the cancer. And so we were able to come up with a combination of drugs that target her HER2 mutation, her HER2 overexpression, and will likely get her a great benefit. Does not mean that her PIK3CA mutation won't be driving the bus at some point in the future, or that her BRAF mutation won't be driving the bus in the future. We'll just keep monitoring her, and we'll testing, and we'll test and determine. And if we see the PIK3CA go up, then we know that we need to start alpelisib. And so this really allows us to determine what treatment at what time. And if you understand precision oncology, you'll know that there's 3 important tenets of precision oncology. It's the right drug. So, is that the right drug for this patient at the right time? And so that's very important, is the timing of the treatments. You don't want to give alpelisib if the person's PIK3CA mutation is not driving the bus. You want to find out which mutation is driving the bus. And that's how these exosome liquid biopsy tests can work, is they can tell you which is driving the bus in real time.
Yeah. For those of you watching at home, if you're pedantic at all, like I am, Alex just said the 3 most important things of precision cancer medicine, and then just kind of mentioned 2.
The right patient.
So yeah. So why don't you say that again? What are the 3 things?
It's the right drug at the right time for the right patient.
There we go. Yes. So you didn't, yeah. So it's you specifically. What is it? First of all, using the discovery panels to figure out the big picture of everything that might be involved, and then using these monitoring liquid biopsies to keep an eye on what's happening now and make sure you're always on the right treatment, and help your doctor have the evidence they need to modify their treatment plan, but to answer questions like, is the immune therapy working or not, or is it time to switch? Should we keep you on another round of this? All those questions can be answered now with 99.9% certainty. I've learned that scientists don't like to say 100% about
We don't even like to say 99.9.
All
We
right,
stop at 99.
But those are the statistics of these tests.
And that's because there's always we have what's called the 95% confidence interval. So in other words, 5% could be chance alone.
Sure. All right, there we go. So pardon me, but yes, the point here is we want discovery liquid biopsies. If we don't have a tumor tissue sample from a biopsy or surgical remnant, we can use a blood-based test that looks at over 300 known cancer-related genes. We're looking at there, or mutations, or you educate me.
Genes, yeah.
And then once now we're in the ballpark and we have a sense of what we want to be looking at for you specifically, then we use these exosome-based, not just any circulating tumor DNA test, but exosome-based monitoring liquid biopsy to see how many of these exosomic metastatic cells are happening for you before treatment, and how many just a few weeks into treatment we can test again and tell you and your doctor with confidence that this treatment is working in an excellent way or meandering way or not what we would hope, and so on, and get you onto the right thing. The most important thing, as you know, with cancer is as quickly as possible, get yourself on the most effective treatment.
Yeah. And so we did a video a little while ago. It was a seminar. We did it with one of our partners, Norgine. Norgine is just an amazing company. And they have really forefronted exosome extraction. So if you are interested in exosomes and isolating exosomes, use the Norgine technology. It's really something. It's the best on the market. We've tried everything. And so we did a great seminar with them. It's been viewed by thousands of people across the planet right now. It's really been well taken in, and we've had lots of great responses from some of the biggest medical centers in the world, very interested in this. So the Norgine part on extraction of the exosomes is the first 18 minutes, and then we start at the 18-minute mark, but we get into details and cover specific cases such as pseudoprogression. And so it's a great video to watch if you're interested to see how this works. Also, you can learn more about the Liquid Biopsy Labs exosome-based liquid biopsy at the link below. And Michelle, you can take it from here.
This is really just a slide so that you have access as desired to how to contact Alex and his team. They are experts on precision cancer medicine, diagnostics and treatments. Really, all of these extra little, but remember to look for this and check for that. And that's really what they do. And they have been at the forefront of precision cancer medicine since it has been a thing, essentially. As Alex mentioned, you know, he and his team were among the first to use immune therapies, and many others. We have a long list of firsts with Alex and his team. And what that really means to you is not only are you going to make sure you're on the best treatment, but we're very skilled at getting oncologists on board with innovative therapies that they otherwise wouldn't even necessarily know to offer you or have the comfort in prescribing for you because it's so new to them. So Alex and his team don't just tell you what's going to serve you best. They really are experts at helping your doctor to get on board and get you the prescription that you need, most of the time with full coverage. Just a little aside there for those of you who might be concerned about that. And of course, we have the YouTube channel here where videos like this one are posted every week. Subscribe, make sure you stay informed and that you are up to speed on all the latest developments for diagnostics and treatments for all different types of cancers. All right.
Right.
Yes, thanks, Alex.
Hey,
I really
I have
appreciate
to run. Thanks a lot, Michelle.
Yeah, you're welcome. Take care.